We talked this morning briefly about the project you had done with a film on patients who have committed suicide. I was curious if you could tell us a little bit about that project, tell our viewers a bit about that.
Well, I've been interested in a long time, having worked with residents all my career, about the impact of suicide of a patient on the resident treating the patient. And so often the resident feels de-skilled, inept, a failure. Some of them even want to leave the profession, thinking they're not suited for it. And in fact, even with experienced clinicians, you see people who are thoroughly demoralized and feel like, I missed something I should have picked up on. When in fact, nobody can predict who's going to commit suicide and who isn't in any perfect way. We have hunches about it. But we worked with Sid Zissuk at the University of California, San Diego, to develop a DVD that would interview both experienced clinicians like Dr. Jim Lomax at Baylor and me, who've lost patients to suicide, and residents. So there could be a discussion of how it affects the clinician treating the patient and provide an overarching message that this happens to everybody. It's an occupational hazard. It isn't a sign that you're a bad psychiatrist or clinician, and that we have to be prepared that some patients will do this in the course of the career, or, you know, otherwise if we try to avoid every suicidal patient to avoid that happening, we're not treating a lot of people who need treatment. So we wanted to convey a universality of the problem within the field. It's an occupational hazard.
Can you imagine this as part of a protocol for residency programs, or as just simply as a resource that's available, say, between supervisor and supervisee?
I do think this ought to be a standard part of the curriculum of psychiatric residents. If they wanted to use our DVD as an adjunct, they certainly could, but it has to be taught, because in the absence of teaching, the natural tendency is to think that I've missed something and I'm not a good psychiatrist.
Right. Yeah, I agree. And I had been with residents who had similar experiences and had wished for some sort of protocol themselves, or a teaching of the risks.
And the other thing, Pierce, I think it involves is within a training program, there ought to be some kind of protocol for a response when a resident loses a patient.
Absolutely.
That the training director, the clinical assignment chief contacts the resident, gets together with the person, talks to them, and lets them ventilate it. And you know, when I was running the Menninger Hospital years ago, we had a team of the hospital chaplain, me as a hospital director, and the nursing director, and we would go to hospital units where suicide had occurred and talk to the staff about their feelings, processing it, and trying to keep them at work with a kind of morale about what they were doing.
Yeah, so Pierce, it's not just for medical students and residents. Even experienced practitioners should actually share that with some colleague and kind of process the issues. I think it's helpful, even for seasoned clinicians.
And you know, Pierce, the reason to have a protocol where this happens automatically is I've had experiences back when I was running Menninger, where I would call up one of the psychiatrists and I'd say, do you want to talk? They say, no, I'll be fine. And I don't think we should be brushed off in those situations.
Right.
I think there ought to be an automatic visit.
Yes.
And sitting down in that guy's office and saying, I know you said don't come, but let's talk about it anyway.
It's a useful ritual.
Because people don't want to admit they need to be helped.
Yeah, I think one of the messages residents had received that didn't have a protocol in place was the message they received from their directors and faculty was, you should brush this off yourself, and they were not
Too heavy.
Yeah, they weren't given that
Heavy responsibility. Yeah. Let me switch gears and ask you about another thing that you do a lot of, Glen, is you see clinicians, physicians, nurses, psychologists, etc., who suffer from stress, psychiatric illness, substance abuse, etc. Quite a few patients, a good chunk of your patients, I understand, are like that.
Yes.
Can you tell us a little bit about what kind of problems mental health professionals usually come to you for, And do you get them back on track? I mean, is the prognosis good for most of them?
It varies according to what the problems are and what their pre-existing characterological dispositions are. I work in a 3-day multidisciplinary assessment program for outpatient for physicians, mental health professionals, clergy, where we look at the stresses of the work, and the problems that are typical are burnout, depression, marital difficulties or partner difficulties, boundary violations where they become over-involved with the patient, or alcohol and substance abuse as a way of trying to deal with the stress. And many of these things will often go together, and a more recent problem that's getting a lot of attention in the physician's health field is the disruptive physician, who is not professional, blows his top at patients and at co-workers, and who may misbehave and not go along with the response to pagers or telephones, not do paperwork, not show up for meetings. And this used to be tolerated, and it isn't anymore. And you have to now treat people with respect and dignity. My most recent book was called Professionalism in Psychiatry.
Yeah, that's a very good book.
Laura Roberts at Stanford,
Right.
and some of my colleagues at Baylor, and we tried to define some of the issues for trainees and also for people who finish their residency about how we act professionally in the face of all kinds of conflicting pulls on us about, well, feeling irritated at people we work with, at the patients. And I think now professionalism has become a major reason for referring people to me for evaluation. Your question about can they get better? Yes, most of them can. You know, there has been a long-standing clinical finding in the chemical dependency field that physicians have better prognosis than non-physicians because they have a lot at stake in terms of their license and practice, and there are programs set up for physicians, and I think that's a model to deal with other problems too, such as with professionalism problems. We have monitoring within the hospital where people are giving 360-degree
Right.
feedback, filling out check sheets on surgeons about whether or not they've kept their cool or treated somebody with contempt. And these kinds of measures are helpful, and not a panacea by any means, but I think there's a lot of reason to be optimistic about the capacity for professionals to get back on their feet.
Good. That's good.
With respect to that, what, personally speaking, what gives you passion? What keeps you inspired in your professional work, whether it be writing, teaching, patients?
Well, I suppose all of it. I feel privileged to be a psychiatrist. I think we have a wonderful occupation that we should never take for granted. I mean, the idea that somebody would tell us their most shameful problems and trust us with that information is a great privilege. And I feel like the most gratifying thing I do is see patients and try to help them figure out their lives. And you feel like you're doing some good at the end of the day when you go home. I also feel like teaching is a wonderfully gratifying role, and I wrote a paper called Why I Teach in Academic Psychiatry that goes into this in detail. It was published just last year.
Yes.
But I think there is a sense of, as the Dalai Lama said, when you share your knowledge, you touch a little bit of immortality. That there's when you teach somebody,
You perpetuate the
you
knowledge,
perpetuate,
yeah.
they're going to teach what you taught them. It goes on and on. You never know where it's going to stop.
Exactly.
And somehow you're influencing a lot more people when you teach, because they're going to teach other people. And there's a good feeling about getting certain kinds of wisdom out there that you've learned from your teachers, and a feeling of being connected both with the previous generations and the generations to come. So that I've always found very gratifying as well. And you know, I wouldn't trade what I've done for anything. I still love going to work in the morning.
Yeah, I told my wife once, I can't believe this job exists and that I get to have it.
And that you get paid to do this as well.
Yeah, like football players, they get paid to play football, which they
That's
love
right.
to do.
Yeah,
That's
sure.
great to know. You're so up on psychiatry because I see a lot of demoralized colleagues. There's so much pressure. The billing issue. The pre-authorization, dealing with the insurance companies, dealing with difficult patients. And the rush of time and being employed
Yes.
and having to produce X amount of money. These are the kind of challenges that demoralize people. But let's never forget that what we're doing is a noble profession.
That's right.
Highest
No matter
caliber.
all of the bureaucratic stuff that we have to deal with, really recedes into the background when you're sitting in your office and the patient is talking to you about problems and you're helping that individual, and all your focus goes in on that patient at that moment.
Exactly.
And if it's not, if you're distracted with all the other stuff, then you might need a little consultation with a colleague to try to get focused on what's really important in that interaction.